All right. Well, listen, for those who are on, again, definitely appreciate your attendance and thank you for joining us this evening for another segment of our Subchondral Solutions educational webinar series. If you've been following us from time to time, you've probably seen some of our recordings and several case studies and amongst other things that have come from this educational series. So we're really excited about it. I'm Brandon Milliken. I'm the Southeastern Regional. And as we continue to explore and highlight various educational topics in the areas of bone preservation, joint motion preservation, tonight's speaker is someone who's extremely well-versed in all aspects of the foot and ankle arena. He's been in practice for over 25 years and has actively worked with residents and fellows as the director of the South Florida Foot and Ankle Fellowship, and also HCA Florida's #1 research program. So could go on and on about this particular gentleman, but just really excited to have him on the team. Great friend of mine and does just an excellent job where he's at. Please let me introduce Dr. Warren Windram out of the Miami-Fort Lauderdale area. Dr. Windram, I'll leave it over to you.
Thank you, Brandon. Also would like to thank Subchondral Solutions for putting this on. This is a great education series. Hope you guys get something out of it that you could bring back to your practice. And we'll try to be as brief as possible, but try to get you some good information this evening. I'm sitting next to my current fellow, Nikki Modah. She'll start off the presentation with some review in regard to osteoarthritis. Our topic tonight is current concepts of treatment for foot and ankle arthritis. It's a pretty broad topic, but I think you'll get some good clinical pearls and clinical information from this that'll hopefully shed some light on these challenging patients that we see in practice, either the ankle or foot. These patients are always challenging, and there's lots of modalities that are out there, how we treat the condition. But I think we're in an environment now where a lot has evolved, and I think it's important to keep up with some of the current concepts and not just keep doing the same thing over and over again, because that's what you've done over the years. So hopefully get something out of tonight's lecture, and I'll turn it over to Nikki for a quick intro and get started.
All right. Yes. So I'm currently the Westside Foot and Ankle Fellow working with Dr. Windram. Did my residency at Westside as well. So you can tell I like it here. I'm just going to get into the presentation. And like Dr. Windram mentioned, we're talking about foot and ankle arthritis, seeing if we're addressing the entire condition. Obviously, there are different levels of foot and ankle arthritis, and when you get to a certain level, fusion is the gold standard, and you cannot possibly do different treatment options. But before that, there's lots of things and lots of procedures that you can do to prophylactically address the deformity that the patient is going through. Give them more time before the fusion, if that is even needed after the procedure. So just going into some basics, osteoarthritis of the foot and ankle usually appears in a younger population because it's usually due to post-traumatic arthritis, which is at a lesser rate than that of the knee and the hip. So many treatment options are not based in clinical studies. We've seen in literature that ankle osteoarthritis is less common in the knee. Ankle osteoarthritis is less common than in the knee and the hip. This is reflected in clinical practice as symptomatic knee and hip osteoarthritis is 8 to 10 times more prevalent. And also just touching base on forefoot osteoarthritis, literature indicates that over 60% of bunions have osteoarthritic changes that are never addressed. So we need to address the entire deformity, and we need to address the joint ultimately. Some diagnostic studies that you can order when you are working up the patients are obviously your foot and ankle radiographs, CT, and the MRI scan. So here's a basic classification. I'm sure everybody's aware of the Tanaka, Van Dyke, Kelligren, Lawrence classifications for arthritis. most radiographs only show you joint space narrowing and osteophytes. You don't get any more information from them, and you can see in these classifications that's really all that they're addressing. A study by Clayson et al. In 2016 assessed different radiographic classification systems, and it came to the conclusion that they were not reliable in decision-making tools for further treatment, nor were they a great parameter for prognosis for post-traumatic arthritis in foot and ankle. Here you can see the MRI classifications and scoring systems gives you kind of the entire picture. You can't base treatment just on radiographs because you don't know about what the joint deformity is like. So you don't know about subchondral edema, you don't know about bone marrow edema, you don't know what the synovium is like, or you can see like this classification here shows you, talks about bursitis, cyst, all these things play in a factor into the ultimate and definitive treatment, which needs to be addressed before the surgeon is taking the patient into the OR and performing surgery. Here is the classification for MPJ, radiographic, as well as the MRI, which just helps give you that complete picture before the patient has surgery. Some treatment options, just going over conservative versus surgical. Conservative options, you always have physical therapy, bracing, shoe modifications, orthotics. Also pharmacological treatments such as NSAIDs. Then you have intra-articular injections, and surgical options. You have two kind of categories, joint sparing and joint destructive. I think with the way technology, everything is moving, we should be ultimately, if we can, leaning towards joint sparing, especially if the patient is younger. No need to fuse their joints because that significantly affects their day-to-day lifestyle. If we can, and we'll go over some literature next, Dr. Windram will, which will show you that what's effective, how effective it is, and we kind of just wanted to get down to the nitty-gritty and go into percentages and see like what is actually effective going long term.
Excellent, thank you. What was interesting about that, because for years, particularly in our podiatry schools, we always were real stern on teaching X-ray classifications for grade in arthritis in both the ankle and the foot. But it's interesting that study showed that really the X-ray classification is it's not real reliable in terms of outcomes. So that's pretty interesting. And you could see from the MRI classification system, there's so much more you could see in a joint than simply osteophytes with joint space narrowing. So, and I think where we are now is that I think we're a little beyond simply treating a simple X-ray. So, and it's an interesting study that showed that it's not real reliable anyway. But yet we still continue to teach it, and we still continue to develop even new classification systems based on X-ray. I find that interesting. So let's get into some of the conservative modalities in more detail. I mean, everyone I'm sure is familiar with, physical therapy for osteoarthritis. The main thing to take from that is that it does increase proprioception at the joint. So therefore, it does help stabilize the joint a little bit. So that's the main reason why we're getting some pain reduction with physical therapy, but certainly not a bad first line of defense for osteoarthritis for either the foot or the ankle. Braces, for the elderly patients that can't tolerate any surgery at all or any other procedures, AFO type braces, orthotics, keeping the foot neutral and aligned underneath the ankle. That's also pretty effective. So as far as conservative modalities, that's pretty basic. Then we have pharmacological modalities, which we all know with NSAID treatment, right? Been around forever. Minimal risk factors. I mean, sometimes there's some drug interactions with anticoagulants. GI side effects are always on your mind with that, and really should not be used for a really prolonged period of time. So, but it's still one of the first lines of defense is still NSAID therapy. Sometimes the topical meds are useful, but their penetration is somewhat limited in terms of how far they can get down, unlike a soft tissue issue. Analgesics really have no place in this discussion because no one really gives pain medication for osteoarthritis. There's really no need for that. So let's get into a little more detail in regard to an intra-articular injection. Like what are our options here? As we know, we have PRP, we have amnio, we have cortisone. So let's look at some studies in terms of like what's working and what's not working out there, right? There was an interesting study with PRP where they actually, they had 100 patients in this randomly assigned study, double-blind study, placebo-controlled, which was pretty impressive, right? Having 100 patients. And what they indicated that they compared PRP with saline, and they did an ultrasound guided injection into the ankle joint. And they basically found that there was really no difference between saline and PRP in over the 26 weeks that they measured it, which I found interesting. In my practice, PRP is probably a little bit more effective than that. That's why it's important to review the literature and see what's going on out there in the world and see what people are finding. Another study you can see on the right side of the screen compared PRP with hyaluronic acid injections, right? And this was a little more positive in regard to it seemed to be more beneficial than simply hyaluronic acid injections. So that was a smaller study, level 2 study, but still and kind of limited in terms of patient size, but it did show that there was a decent amount of progress from simply using hyaluronic acid. PRP was better than that. So in looking at hyaluronic injections or hyaluronic acid injections, this was a pretty decent article that was published back in 22, and it did conclude that three weekly intra-articular injections, one a week for 3 weeks, can be performed to reduce pain and any serious complications with intermediate and early stages of osteoarthritis. So that and hyaluronic acid has been used for years in the knee, and it's kind of a mainstay, but it's interesting that the previous article showed that PRP was better than hyaluronic acid. And there's other studies as we go on to show that it's even less effective than that. So I'm not sure, how effective hyaluronic acid is, but some docs, use it. Now, our mainstay, right, corticosteroid injections that we use pretty much daily in the clinic, correct? So the one study on the left showed, it was a pretty good study, and it did show that there was definitely short-term relief with cortisone injection, but it drastically dropped after 6 months. So, and other studies kind of back that up. Even the study on the right also states that there was significant improvement initially, but then as time went on, there was definitely less improvement, particularly 6-month period. And that's pretty much what we tell our patients. So there's no real curative agent with corticosteroids, right? It just helps the pain. There's no X-ray or range of motion improvement. So it's just more or less for pain relief. So, but it's one of the few injections that insurance companies cover, right? Even though it's temporary, it doesn't really make much sense, right? So let's move on to amniotic injections. Kind of new, right? Exciting stuff with that. No live cells in amniotic fluid, right? Just a bunch of growth factors, antimicrobial components, hyaluronic acid, stem cell activators. One interesting study with that, with Jack and all, was that it was a pretty cool study what they did, because they compared saline injection, all right, with hyaluronic acid and then amniotic. So they had three groups, right? And if you look at the results, which was pretty interesting, 75% had unfavorable pain in 3 months. So that means 25% of patients got better in 3 months with just a saline injection. So I find that interesting. And hyaluronic acid, not so much better. All right. Close to like 68% unfavorable. But then surprisingly in this study, right, the amniotic fluid did very well, almost like 87% success rate in 3 months. So I found that pretty interesting. I'm not surprised. This is due to the nature of what amniotic fluid is when we compare it to hyaluronic acid and saline. So the conclusion is that the amniotic allograft injection is favorable in terms of treatment for symptomatic knee OA. So, and it's pretty significant. It was a 200 subject randomized study, which was pretty impressive. And again, like we mentioned in the beginning of the presentation, most of the studies are centered around the knee and the hip because they're a lot more prevalent than arthritis in the ankle and the foot. So, but we could still extrapolate from some of the findings that it should be just as effective in the ankle as the knee. So, and last, in terms of injection therapy, mesenchymal stem cells, which are live cells, either get them from either adipose tissue or bone marrow. And there's very little studies on that to support the use of it. I mean, Adam has a little study with 6 ankle patients, they all improved. So there's favorable knee studies out there, but again, this topic here needs to be further examined. But there's also a lot of issues with this topic because, where do you get the stem cells from? If you use adipose tissue or bone marrow from a patient who is older, how much active cells are we actually getting? So do we need to get them? So that brings up a whole other issue. So that more or less summarizes what we more or less can inject into a joint, right, to treat osteoarthritis. So hopefully that helps you, because basically we really do need to look at the study results, like what's happening out there in the world, and are these things actually working? So the next stage we'll go into is really the meat and potatoes of this lecture is more or less the joint sparing procedures. Like, I think we've evolved to this point where, aside from, if a patient fails a cortisone injection and physical therapy, we go fuse his ankle. I think there's something in between that we can do in today's market where there is more to offer patients at this point. Some of the procedures that we're talking about, sometimes they're a little technically difficult to perform, but I think, these need to be your primary focus in regard to treating OA/OCDs of the ankle or foot, whatever. These need to be your primary focus in terms of your treatment regimen. You could certainly do it in conjunction with PRP or any of the amniotic or stem cell injections. You can do these joint sparing procedures in conjunction with that. So let's look at like arthroscopic ankle debridement. How successful is that? I mean, there's a couple of studies that show that again, short-term results. I mean, they had real favorable results from an ankle arthroscopic debridement, where there is, the first study with CHOS indicated 63 patients, a good size, and they looked at the ankle joint itself. This is not a knee study, and they followed them for 6 months, but then they said that patients did really well for 6 months, and then it started to go downhill, which we could expect that, right? We're not curing the arthritis by doing the arthroscopic debridement. Another study showed, which was interesting, that, and this is a really interesting study, where if we have a soft tissue impingement in the ankle, like an anterior impingement, scopes work really well for that. Debridements work really well for that. Almost no patients came back in 5 years. However, if there's arthritis in the ankle joint, 30% of those patients went on to bigger surgeries after 5 years. So again, significant in regard to, what are you actually treating when you're in there, right? So you may have an arthritic ankle, but if you have a lot of anterior impingement, you could expect more positive result.
Yeah, and we know with osteoarthritis and osteochondral lesions in the ankle too, that changes the biomechanics of the ankle. So you have pressure, the pressure that's going through the ankle is not dispersed.
Correct.
How it should be. So that leads to further post-traumatic changes and further degradation of the joint, more arthritis.
Right. So another study showed, this was an interesting one, professional soccer players. They followed for 7 years with 15 former soccer players. And they did very well with arthroscopic debridement. And interestingly, that it was a really long-term follow-up, 7.5 years. So interesting. I mean, they didn't really give us much detail in terms of what they found in the ankle when they scoped these guys. It could have been mild, soft. We don't know. So that study, I'm a little questionable results. Now, some doctors like to do this. I've done some of these cases. Patients usually aren't very happy with having the X fix on their ankle for a little bit to kind of distract it. But this study clearly shows with distraction arthroplasty, coupled with an arthroscopic debridement, it helps the arthroscopic debridement significantly. As opposed to just doing an arthroscopic debridement, you're doing arthroscopic debridement along with the ankle distraction, and there has been a significant improvement. So So complications were more prevalent in patients that just did the ankle arthroscopic debridement as opposed to using the distraction arthroplasty. It's an older technique. That's not a new technique. That's been around. So interestingly, on this slide, it's interesting with the incidence of OCDs or OCLs and with ankle fractures, because this is interesting in terms of, you know, just the sense of what's the percentage of OCDs, you know, joint injury after an ankle fracture, like what's going on? I mean, studies, most of the study, the first study here is a level 1 study, all right, it's showing almost a 60% without a scope. With the scope, was almost 70% incidence of articular damage following a simple ankle fracture. We're not talking about a pylon fracture. We're talking about a simple ankle fracture, bimal, lateral mal, and there's a real high incidence of joint damage during these fractures. Why aren't we addressing that? Okay, that's where we, you know, are we addressing the whole picture? So, and also the study on the right, you see it's a level 2 study. It's not a level 1 study, but still indicates that long-term follow-up of 109 ankle fractures found that the initial cartilage damage is an independent predictor for the development of both clinical and radiographic post-traumatic arthritis. So that's significant. I mean, we see these patients in clinic all the time. 5 years after an ankle fracture, they come in with ankle arthritis. Why? The x-rays look perfect in terms of fixation, right? Everything's fixed, everything's healed, but, you know, we're failing to evaluate the integrity of the joint during the fracture. So various techniques are seen then to like approach the OCDs or of the talus, and, you know, who've been around since the beginning of time, micro fractures, right? A little barbaric in terms of the procedure itself, but studies pretty much, there's lots of studies on it. They usually hover around 50 to 60% in terms of success rates. Again, they're not really classifying the extent of the OCD, and it's kind of basic, all right? So I would say it's probably about successful about 50% of the time. So, and simple, you know how to just fenestrate the subchondral bone, whatever, with a pick, or drill, a wire, whatever you're going to use. But that's been around since the beginning of time. It's been the mainstay of a joint preserving type procedure. Now, even earlier than that, we had Oates procedures, mosaic plasties, where, you know, it's an autograft from the femoral condyle, where it takes both cartilage and bone. And the issue with that procedure is the donor site morbidity could be as high as 30%. I've seen articles go even higher than that. I mean, who wants to fix the ankle and have knee pain, right? So again, it addresses it's interesting because the Oates procedure does address both the subchondral issues as well as the cartilage, all right? Whereas a microfracture is really not really addressing the cartilage at all, and it's just more or less stimulating bone to bleed. I don't know really how much it's doing to really properly decompress the subchondral bone. So in Oates procedures, some docs still do those. Again, in podiatry, it's kind of rare because we have to get an ortho guy to take it from the knee. Earlier in practice, we used to do this a lot. I'm sure everyone's familiar with the subchondroplasty technique. That's an interesting procedure in regard to, they've done a study and they said they get a decent result. You can see the study in front of you. They get a decent result from the 1 year follow-up with the 10 patients. It's a smaller study, but in general, that study showed that it is effective. Now, what I see with subchondroplasty is that this is the first product that's really identifying an issue with the subchondral bone, right? No one's really done that before. So it's kind of like a step forward from a microfracture. Then we've evolved to a subchondroplasty, which really addresses the subchondral issue. However, if your cartilage is involved and you have a defect in the cartilage, it's possible that the injection that you put into the talus may extrude into the ankle joint, which is a pain in the neck to take out. And it just takes forever with the scope to take all that stuff out. So that's an issue with this procedure, as well as AVN for overstuffing the talus, and because the procedure they're actually doing, it's not real precise. But I give them credit because they taught us that the subchondral bone is the issue with these patients with pain. It's not that little small cartilage flap that's the issue. it's the subchondral injury. All right. And subchondroplasty has at least demonstrated that to us, that, you know, that's something that needs to be looked at. So again, I bring up the question, you know, are we addressing the entire issue? Like back to the ankle fracture studies, right? With the, I mean, come on, 60 to 70% joint damage after a simple ankle fracture, and we're not even looking at that. So the question is, and even with bunions, there's a 60% occurrence of OA at the level of the first MVJ after HAV surgery. We're busy correcting the deformity, but are we actually treating the whole issue? So, and I think we're better at this point in terms of our evolution, that we have the ability to look at these joints with better diagnostic studies. And then at the time of the fracture, even if you have a medial malleolar fracture, a lot of times we can get to the lesion from not even doing a separate incision, right, from the medial malleolus. If we could distract that a bit, we may look right at the damage if it's medially in the talus, right? So, and just keep that in mind when you look at an ankle fracture. So, and we have the same theory with bunions, all right? So, and again, the advanced imaging is important in regard to really seeing the whole picture. And with a simple x-ray, and it's not only me saying that, studies have also shown that x-rays are just not reliable, okay? So that brings us up to S-Core from Subchondral Solutions. And an interesting product, all right? It's been out for a while now. It's been working really well. And this product, it's interesting, all right? It's a titanium alloy, certainly wrapped with hydroxyapatite. It's fenestrated, so growth, you know, bone growth into the implant is pretty rapid. And being made of titanium, pretty inert. There's really no rejection issue going on with that. And you have the option of attaching a dermal graft. Normally we use about a 3 centimeter dermal graft, and we could attach that to the implant, FDA approved. We could attach that to the implant and then insert the implant. So 2 things are happening, right? We're addressing the subchondral injury. All right, number 1, the subchondral injury is the important thing to address. If we don't provide a stable platform in the subchondral bone, it doesn't matter what you do to the cartilage, it's never going to heal. So the cartilage does not grow downhill. So if you have soft bone underneath it, you can microfracture that until the cows come home, and you're still not going to develop hard bone there. So, and it's going to be a defect, and it's not going to cover with cartilage. So with this implant, because it's put in precisely just beneath the articular surface in the subchondral bone, it does not extrude into the joint like a Cartiva did, and basically provides that scaffolding of the subchondral bone, which we know is the issue. If you have really healthy subchondral bone and this thing regenerates the subchondral bone, we have a real high chance of developing, you know, type 2 collagen across the defect. So you could see it comes in different sizes. You know, we could go from a 6 to a 10, simple application, simple guide wire, simple reamer. And again, you know, based on our diagnostic studies, we could have this ready before surgery, okay? And it makes it a lot easier from a simple chilectomy that we're doing, a hallux valgus surgery, an ankle fracture. If we know what's going on in the joint, these are simply put in. It doesn't take a whole lot of time. You don't burn any bridges with it, and it's been working super well. So I applaud Subchondral Solutions for coming out with this. I think it's a good takeoff from the subchondroplasty we were talking about, that kind of addressed the subchondral edema, but it didn't really provide a scaffold, and it was not very accurate. Because I did have one case of AVN after filling a talus that has cystic talus changes, and we filled it with the subchondroplasty, and it did go into a full AVN. So that is a drawback with it, but I give them credit because of the fact that they did bring attention to the issue with the subchondral bone. But S-Core really brought it over the top by really, hey, this is it. Let's do it. So it was pretty simple to move forward with that.
Okay.
So if we look at it's an interesting case, very simple case, right? I mean, it looks probably like, I don't know, 2, maybe early 3 on the left X-ray, a little dorsal osteophyte there. Real not too bad. It was a 50-year-old male who came in with joint pain, failed conservative care with injection therapy, you know, physical therapy, shoe modifications, orthotics. So we decided to do an MRI, and you can see the MRI picture on the side. Now it tells us the whole picture, right? Because on the X-ray, you look at it, you say, I got a dorsiossified, minor joint space narrowing. But if we look at the MRI, lo and behold, there's the subchondral edema, okay? And if you look at the bottom picture on the lateral, you can see where we put the implant, where we put the S-Core implant was right in that area, okay? And unlike if anyone's familiar with using the Cartiva before, the Cartiva had to be put in a particular way that had to be straight in the bone, right down the medullary canal. It couldn't be any variation in the direction. So with the S-Core, it goes into the area of pathology, okay? So that's the key. So you could just picture the size of that S-Core implant more or less took up that whole area of subchondral edema in the first metatarsal head. And you can see on the AP, it's below the joint level, but within that spot is obviously dermal graft. So again, not very obtrusive, and again, following the area of pathology based on our MRI. That's the key, okay? And today the patient's doing very well. This particular one, I believe, is out 16 months. This one, the first one, he's been out 16 months, back to his regular activity, law enforcement agency, and he's doing very well with it. Again, avoiding a fusion. And then we did one on a lesser metatarsal. This was, I believe, more of an AVN case. But again, with the advanced imaging, if you look at the X-ray on the left, all right, what's going on there? Maybe a little cyst, can't really tell, right? But then if you look at the MRI, bam, it's like, all right, there is our issue. So again, this was a younger patient, probably 30 years old, automobile accident, I believe, like 2 years prior. Again, failed conservative modalities, therapy, injections, shoe modifications, and then you look at the post-op picture on the right, again, in the area of the subchondral edema. And remember, in this particular case, it was interesting. The cartilage looked like it was intact. However, very cushy. You could push your finger and it goes all the way down. So that's an excellent example of, if the subchondral bone is bad, I don't care what your cartilage looks like. It's not going to work. Nothing's going to grow there. So need to have a stable platform, and the S-Core provides that. And we obviously witnessed it in the first met. Here's a talus OCD lesion of the medial shoulder, which we know, treating arthroscopically is a little challenging, right? We have to do a medial malleolar osteotomy, get it out of the way. But with the shoulder lesion, this implant, you could see if you go see the implant being on the right upper screen, you see the dermal graft being attached to the implant. And then simply, after the guide wire drill and reman, you simply insert it. It can't get any more simple than that, right? It takes a little work to get there, but if you plan properly, with the surgical procedure, you're going to do an osteotomy, it can move along pretty quickly. So that patient's also doing very well. So if we look at this one, a recent case we had, a revision case. It's an interesting case. I mean, it's a 70-year-old lady. I mean, she has bad arthritis in the first toe joint, the first MPJ. She has bad arthritis there. We could see that. All right. We did a Cartiva. Now, in the day when we did the Cartiva, we put a 3 millimeter headless screw in the medullary canal at the base to prevent subsidence. That was the goal of putting that screw in there. All right, because we knew there was issues with subsidence with the Cartiva. So, and you can see the X-rays. You can see the X-rays that show that the screw. I mean, the screw's in a pretty decent place, right? It's right at the bottom of where the Cartiva implant would be. And again, we're not really seeing the Cartiva implant because you can't really see it on the X-ray. But if we look in surgery, which is interesting in surgery, you can see the picture on it's 3 years. This Cartiva was in for 3 years. If you look at the picture on the left, the intraoperative picture, you could see the Cartiva has completely subsided, right? It's inside beneath the cartilage, which I wasn't too surprised. I figured I would see that, even though the screw was in proper position, the screw did not move. It still subsided, and we were easily able to pull it out with a freer elevator. You could see that, it almost fell on the floor. All right, as we pulled it out. And what was interesting about this, when we took it out and looked at it closely, there was no biologic activity of this implant, meaning that there was no bone growth We simply came out, the cancellous bone beneath was completely hollow like it was when we put it in, and the screw head was right there. So we were able to just back the screw out and then size it properly, and then put an S-Core in with the dermal graft. You can see that in the upper end with the dermal graft attached. So what was interesting about this case is that how inert that spacer was. So we've come to learn that Cartiva more or less was a very expensive joint spacer that really was, I don't know why it would continue to subside, but it did. And in this particular case, I just found it interesting that I did not have to struggle to get this out. When I first looked at it, I go, oh, this is going to be hard to get out. But it just popped right out. It almost fell on the floor. Like I said, there was completely no biologic activity around this device. And with this particular patient, she was adamantly against the joint fusion. If some viewers are thinking like, why didn't you fuse it? But the patient did not want a joint fusion, so we gave her this option. And she's about 3 weeks out now, doing well, but we'll see. It's still relatively soon. Let me see the S-Core X-rays where the S-Core went in. And we guarantee you, if we take this S-Core implant out in 3 years, it's not going to come out that easy. You know, you're going to get a lot of ingrowth there. So we found that pretty interesting. So pretty excited about being able to use a product like this. We're not producing any comorbidities at the knee, doing an OATS. We're doing more for the patient than an antiquated microfracture technique. All right, which I still believe is very antiquated. With the literature mostly points at about a 50% success rate, which I don't think is real high. If you're presenting that to a patient, I think, you know, we're going to get right half the time. I mean, I don't know. I would, if I was a patient, I don't think I would like that. And then, you know, we thank the subchondroplasty to bring attention to the fact that the subchondral edema, insufficiency fractures, microfractures in the subchondral bone, is a main concern here. And the only way we could properly identify that is with proper imaging. So just keep that in mind. And just moving on to be complete, certainly joint destructive procedures are out there. You know, joint fusions, ankle arthrodesis is there. I mean, most of the studies have shown with an ankle arthrodesis, we do see a decent amount of arthritis in surrounding joints, both knee, forefoot. So not the greatest procedure, unfortunately, still warranted sometimes, but it should be pretty rare. All right, it should be pretty rare. The ankle joint arthroplasties with the total joint implants have been working super well with that when you get to that stage. Okay, but you know, the main part of this lecture is not to discuss that. It was more to discuss how do we prevent coming to this stage, or how could we postpone coming to this phase of joint fusion or total ankle implant. But as far as like ankle arthrodesis, I really don't do a whole lot of those because of the complication rate with the other joints breaking out, show parts joints, subtalar joint, and that patients aren't very happy when you have to do more fusions in 10 years. So I think we owe our patients more than that. And then total ankle arthroplasty, great procedure when you get to that point, when your ankle's completely shot and you need to replace the ankle joint. Would like to see this done all the time as opposed to fusions, but again,
we're trying to prevent that.
Yeah, the whole point of that, the middle section, is to try to prevent all of this if we can really do our joint preserving procedures correctly. So, and I think with what's available today on the market, particularly with S-Core, I mean, I think we have a lot of options, and we really don't burn any bridges. So I think it's a really good alternative. So in conclusion, you know, the main objective of the treatment of ankle and foot osteoarthritis is to control pain, maintain the joint, and certainly we recommend doing adequate imaging. All right, X-ray, MRI, CT scan, whatever it takes to give you a full picture before you go in the operating room. For mild to moderate stages, treatment options, you know, could provide relief, you know, like we showed, and try to avoid the joint destructive procedures. And you know, early stages, you know, corticosteroid, hyaluronic acid, stem cells, we win all the success rates with that. You make the decision if that's something that you would like to do based on what the literature is showing. But in patients with early stages of osteoarthritis, we really do need to have discussions with our patients in regard to, you know, what they're experiencing. And you'll be surprised, you know, once you explain in detail to them what your objective is to preserve their joint, not to destroy the joint. They're very excited about that, and postoperatively they reflect that. So if they continue to have a little stiffness, they're good with that as long as their pain is better. So, and they're happy they didn't have to go through a joint fusion. You could always do a joint fusion, right? There's nothing, after that, you don't do anything, right? So I think, having these middle ground procedures, particularly the platform procedure of S-Core, where we actually maintain a platform to allow type 2 cartilage to grow back, collagen to grow back over a joint, I think that's the game changer, because again, other procedures, they address different things. They don't address the whole thing. Oats tried, right? Because it gives you the autograft as well as the cartilage and bone, but at the end of the day, who wants knee pain 30% of the time, right? I don't want my knee to hurt after my ankle's killing me. So, all right, that's our presentation. Hope you guys enjoyed it. Any questions? We're here.
Yeah, Dr. Windram, I think there's a few questions.
Perfect.
Great presentation. I mean, I think this is just such a great overview. This could really lead into about 1,000 questions, but we'll try to keep it a little quick and short. One question was, can you just touch on the rehab protocols for both first MPJ and talar dome lesions as it relates to the S-Core compared to maybe some of the other technologies that you mentioned tonight?
You mean post-op protocol?
Right. Yes.
Yeah, I mean, basically, we really don't, in terms of the ankle, I do keep them non-weight bearing a little longer than the first MPJ. First MPJ, more or less, they're, first post-op visit, they're in a boot, they're in a cam boot. And we begin some early range of motion immediately of the first MPJ. Usually use an absorbable stitch like a monocryl, so we can get them showering and get them moving. So not a whole lot of non-weight bearing with the first MPJ. Early range of motion, cam boot, that's about it. And they're usually back in shoes in about a week or two. They usually move pretty fast with it. But the ankle, depending on where the lesion is and how big it is, I do keep them non-weight bearing. I'll put them in a boot, but I'll keep them non-weight bearing with crutches for about 3 weeks before beginning rehab with it.
Okay, great. Thank you. I was going to ask, I mean, I think you uncover a few things where, if you look at why aren't we doing this, right? Why aren't we establishing additional MRIs for, even bunions? I hear a lot of the times for bunion and you get really good alignment, but yet, maybe sometimes post-operatively patients are coming in and they're doing weight bearing range of motion. And sometimes mid-motion, there's some continued pain amongst other things, which kind of tells you, hey, there's just something more going on, which alludes to exactly what you discussed tonight. And so getting, the clinical, I guess, treatment algorithms changed, so to speak, you're seeing opportunities for this, but I think it all comes down to cost, correct? Can you talk a little bit about how, the importance of technologies like S-Core related to outcome data or relevant clinical evidence that maybe CMS potentially evaluates to determine insurance coverage, et cetera. Can you talk a little bit about that, changing the game a little bit for the purposes of insurance and coverage and reimbursement for these types of things?
Yeah, I mean, certainly it's going to be a challenge. I mean, trying to change routines are going to be a bit of a challenge, particularly when we're talking about bunion cases. For instance, a lot of times after we do a bunion surgery and patients still have some joint pain, or our response to the patient, oh yeah, that'll go away, it's just from the surgery. All right, even if we did a lapidus, we didn't even touch the first MPJ joint. So I think in terms of cost savings, I mean, if we're doing the procedure correctly, because again, in my opinion, we're not addressing the whole procedure. So what, you have an IM of 20, okay, great, we could fix that, but what does the whole picture look like? What does the joint look like? And we know studies show that there's OA in the joint about 60% of the time. So we get this excellent correction, but yet we still have stiffness and pain in the joint. So a lot of docs just like chalk it up. Oh, it was your bunion. Don't worry about it. But I think if we address it at the time, overall, we're going to save money. All right. We're going to save money down the road for avoiding extra, other surgeries. And also if we adequately image the patient prior to surgery with an MRI, and MRIs are pretty cheap today. That also is part of the deal, which will hopefully lower costs down the road in terms of more treatment, more medical treatment. So, and further surgeries, joint fusions and all that stuff. So the whole point is to not get to that ankle replacement, that $30,000 ankle replacement. The whole point is not to get to that. And if we could address these things earlier, look at the statistics with ankle fractures. I mean, it's almost 70% of ankle fractures have articular injury, and we're not addressing that when we fix the ankle. Put our screws and plates and we're going home. All right, and then we wonder why 5 years later we have all this post-traumatic in ankle. So post-traumatic ankle changes, right? So that alone itself will prevent further cost in terms of further surgeries down the road. So these things need to be addressed initially, and it's when we first started doing these things with hallux rigidus. It's real simple, right? Because you're looking right at the joint, right? You could see if there's some cartilage damage, but again, we're really not seeing the health of the subchondral bone. Even when we're looking at it, we're not seeing it. So an MRI, like you saw in that one case, showed me exactly where the issue was and where I was able to put the S-Core implant. So you tell me, if we could avoid a further surgery with that guy, it's like 50 years old, right? If we could avoid a first MPJ fusion or multiple visits for injections and all that stuff, we're certainly saving insurance companies money by doing the right procedure initially. People got to get out of their comfort zone and just say, hey, I'm going to order an MRI. I want to see what's going on, particularly in bunions that have a lot of joint pain. It may not be just bump pain. Do an MRI and see what your joint looks like. I mean, if you have to go up, if you're doing a distal osteotomy or if you're doing a base procedure, whatever, just, what's the big deal if you have to address the cartilage? So in the past, if you saw a damaged cartilage, you'll just simply microfracture it and then leave it, right? But we know from the studies that there's a lot more going on than simply microfracturing it, and I think with the MRI exam, you'll know where your issue is. And, as the years go on, we will start to see this more and more. And I believe our outcomes are going to be pretty good. And overall, in terms of in saving money, I mean, certainly that's going to save subsequent surgeries.
Okay. Just a couple more quick questions, and I think we'll wrap up after that, if that's okay. One question is, with the advent of technologies and biocompatibility of products, et cetera, do you have any concerns about, metal in the joint, S-Core being a metal titanium product, maybe versus some of the other, like a Curtiva? Obviously you touched on that, but, do you have concerns, as far as the longevity or potential outcomes because it's a metal implant?
No, I don't really see it. I know we bill it as a joint implant. I don't really see it as a joint implant because it's sitting in the subchondral bone. All right, it's fenestrated, it's threaded, it's not going anywhere. All right, it's not going anywhere. It's not going to move around like the Cartiva does, right? And we prove that there's zero bioactive processes going on with that Cartiva. It's just like a dead piece of plastic in there. It's doing nothing, right? So with the S-Core, it's gonna be a little more interactive, right? The bone is gonna grow in there pretty solid. And I don't anticipate it migrating into the joint. I haven't seen that yet, right? Because I think because it's threaded and it's porous. I don't think we're gonna see that. So it's a very stable implant. As time goes on, we may develop more options for the articular surface. Right now we use dermal graft, whatever, but we have that's pretty exciting stuff moving down the road in terms of what we could use biologically for the joint surface repair after we put the S-Core in, because we know our base is good, right? We know the subchondral bone is good. That thing's not going anywhere. All right, pain's going to be less because the subchondral edema is gone, the insufficiency fracture is gone, but the articular surface, I see us evolving with that over the years in terms of getting some pretty cool products that may speed up things, or it may be a little bit more predictive in regard to outcomes in terms of type 2 collagen growth.
Got it. Okay. One other question. This is probably the last one, I believe, that I see. What about talar dome lesions on the shoulder that aren't completely contained with cartilage? That are in that difficult location, literally right on the shoulder. It could be medial lateral. Any thoughts about that?
Again, I mean, they're challenging. I mean, the shoulder lesions are challenging, but they're pretty common, right? Particularly the medial shoulder is pretty common. So I know trying to get at that just simply arthroscopically is a challenge. So, but if the medial malleolar osteotomy is done and through MRI we know where a lesion is, we know where to make the osteotomy and how big, there's really no issue with that. I mean, you could see, because you could use all different sizes of the implant, And you could see from the x-ray from that one that, if it's placed in properly, it's dome shaped. So it really conforms nicely to the medial edge of the talus. So I see no issues with using this on the lateral medial edges of the talus. I mean, it beats the alternative, right? It beats the alternative of doing, an allograft, cut the corner out, put an allograft with a headless screw. I think it beats that hands down. So.
Right. All right. Listen, I think that's it. I don't think anyone has any other questions. Want to thank everybody for attending another great segment. Dr. Windram, thank you so much for your time. And we'll have it recorded, so we'll be able to redistribute this out to all the attendees and other interested parties. But again, thank you, and be looking out for our next upcoming webinar. And we'll be posting that on LinkedIn. So again, thank you for everyone who was able to join us tonight. And we'll talk again soon. Thank you again.
Thanks.
Thank you.
Thank you, guys.